And it's helpful, I find it very helpful to have the chat open. For all of our attendees who are joining now, I see the numbers going up. You are most welcome to our PrEP Learning Network webinar. We're going to give this a few moments for folks to join. We do have all the lines muted just for the sake of clear lines, but we have an open chat. It's generally been a very a robust chat where folks have been felt free to share thoughts and questions and comments and insights. So please keep your chat box open, and we will begin in another minute or so. I see a few more folks are joining. Welcome to the PrEP Learning Network webinar. We're going to begin in just a moment. Okay, I think we can go ahead and begin. This is Christine Torjussen speaking. I'm from FHI 360 and the director of the Options Consortium, and we are co-leading this webinar series with EPIC and RISE, which are two other USAID funded projects focused on HIV prevention, care, and treatment. We're very excited today to welcome you to this discussion on using human-centered design to bridge the disconnect between providers and end users in PrEP programming. I think next slide, Martha. So this is the outline of our webinar today. We're going to talk through some definitions of different research approaches, and Annabelle Gomez is going to share insights from South Africa and Kenya. And then we're going to hear from Zambia Discover Health Project on how they have used HCD to inform the development of provider tools, and then close with our future presentations. So I already see a question about whether slides will be shared following the webinar. So I will mention that yes, indeed, we will be sending out a resource sheet. We have a web page actually that has all webinar slides and all resource sheets available. And we will share the link to that it's on the final slide here. In the meantime, I just want to note that we have muted lines because of the number of attendees and trying to keep the line clear, but we very much want this to be an open conversation. So we have a chat box. You'll notice that if you see the two line there are two different options. One says all panelists, and that means your questions or comments only come to those of us on the panelist page, which is a small number of people. So the best is to write to all panelists and attendees, and that way everyone can see your questions or comments. We welcome you if you have your own experiences to share to go ahead and put those in the chat as well. So moving on to the next slide, we're going to go ahead and begin. Next slide. I'd like to turn this over now to Annabelle Gomez from AVAC to talk about research definitions and her experience using HCD. Go ahead, Annabelle.
Thanks, Christine, and good morning, good afternoon, good evening, everybody. Thank you for joining. I might be moving through this quite quickly, but you do have my email address at the end of this presentation, and anything that I miss, please reach out to the options team or to me directly, because I will be moving through this quite quickly. If I can go to the next slide. As Christine said, we'll be covering some definitions of a couple of research approaches that you will hear during this presentation, and that some of you may have heard in the field already. And we just want to make sure that we're all on the same page when these definitions come up and we understand what we're talking about. And then talking about outputs from primarily the South African project, but drawing in some insights from the Kenya project run by Japago called Jalindi. And we also have somebody from that project on the panel ready to answer some questions if you want some more detail from that. So next slide, please. So one of the first terms I want to talk about is behavioural economics. What is it and how is it being used? And really, we expect human beings to make rational, data-driven decisions, and they don't. We are not rational beings, and for the most part. And what behavioural economics does, it really looks at the effects of emotions, culture, social factors in economic decision making, and then trying to really give you a very cohesive understanding of where those decision points are and what drives those decisions. So the why you are maybe choosing to take PrEP and not take PrEP, and what really affects that decision deeply. So beyond what is a barrier, but why is it a barrier and how we can maybe address it. And in the cartoon there, you see how when a pair of shoes are $100, nobody really wants them. But when you think they're on sale and they're half price, boy, everybody's going to fight for them. And that's that same thing of behavioural economics. How do you really, in marketing, if you like, get into somebody's head to make something appealing, to make them feel that they've got a good deal, to make it something that is desirable and that they want. And a lot of you who go, you go shopping in the supermarket or the chemist, and you go down the aisles and the checkout aisles, and you'll see lots of little hand lotions and lip balms and all sorts of things lining the aisles, and they're like little nudges as well that get you to maybe buy something that you wouldn't normally buy. That again is behavioural economics. How do you get people to do things that they wouldn't normally do? And this is really by deeply understanding what drives decisions and how do you nudge that decision along? How do you frame things and how do you approach things in a way that makes people want them? And I'm going to finish off this presentation with another B slide, behavioural economics slide, that I hopefully will help hammer home the point of what is behavioural economics. Next slide, please. So the next term that you will hear about, certainly about in the JSI presentation, is human-centred design. It's at the heart of a lot of the work that is being done out there. Programs like Adolescent 360 were very focused on human-centred design, and you'll see it more and more. And as you can see in that picture, you've got some architects who've probably put a lot of effort into making that lovely straight path with all those nice pavers. But really, that's not what people wanted. What people wanted was a shortest route from A to B, and they've just cut across that. And that is good. That is what you see as bad design. That is a design that, while it looks really pretty, it didn't in any way take into account what human beings want and why they want it. And so human-centered design is really about this bottom-up approach by really speaking to people and getting deep knowledge about what they desire and why they desire it. It is a very powerful tool. It's one of the, it uses something called ethnographic research, which is different forms of research. It goes beyond things like focus group discussions. There's a lot of different techniques. It could include, living with somebody for a week or following them for a week, but just having a deep, deep knowledge of that person's life and really understanding and framing the problem that we have in a manner that is relative to their life. So really framing problems in a manner that takes into account their whole ecosystem. And there are sort of three key steps to human-centered design. You need to look for inspiration, and that's talking a lot about the research that we're talking about and how you get this very deep knowledge of a human being. Then there's something called ideation. So it's to come up with solutions to solve that problem. And these solutions are not undertaken by programmers and implementers alone. It is very much about having multidisciplinary teams come up with solutions, but most importantly, the people that you are solutioning for are part of that multidisciplinary groups. They are very strongly in that room and telling us what they want, and we are listening to them. And the last part of that is implementation. That implementation is of prototypes of service delivery of a product that gets changed over and over again until we get it right. One of the great beauties of human-centered design is flexibility is built into it, and the ability to change quickly to get things right is a hallmark of human-centered design. So what that means is that you may have a prototype that you think is great, but it might not work. But you can fail quickly in human-centered design. You fail quickly, you fail cheaply, and you move on until you get it right. And it is really that nexus of what is desirable, what people want, what is feasible, can we build it, and what is viable, can we deliver it? And you'll hear more about this later on. Can we go to the next slide, please? So I'm going to move across to the focus of this work, which is the South Africa study primarily. And the objective of this was really to understand adolescent girls and young women who were likely to use prevention products, not specifically PrEP, but just generally prevention along the way, and then how we could reach them, how we could identify them, and what do we reach them with. And it's really, and what is that maximum? What were the barriers to uptake and adherence that were the biggest ones that we needed to develop? This is a 2.5-year project, and you can see we've done the human-centered design is in the second part of the project, and the earlier part of the project was the behavioural economics work. So if we can go to the next slide, please. Just very quickly to talk to you about who we spoke to. We actually in total spoke to well over almost 3,400 people in total. I'm going to speak about the qualitative work, which is where we focused on community healthcare workers, nurses, matriarchal figures, and male partners. But the three in the box is what I'm going to speak about primarily. We spoke to these groups in 2 provinces, KwaZulu-Natal and Mpumalanga, and there was no age limit on the community healthcare workers, nurses, or matriarchal figures. With the girls, it was age 15 to 24. And it was both in rural and urban areas. I'm going to focus most of this discussion on community healthcare workers and draw out where there are relevant insights or the same insights with nurses and matriarchal figures. And just for definition's sake, matriarchal figures could be mothers, grandmothers, aunties, nurses, big sisters. We just didn't want to limit it to mothers and grandmothers. We really wanted to talk to women who really affected decision-making lives of adolescent girls and young women. Can we move forward, please? This is the last, an IDI, sorry, Ricky, is individual conversations with people as opposed to focus groups. And thank you for picking me up on any jargon, and please feel free to do that as any of us move forward. So this is one of the other things you'll learn about, and I'll probably refer to, is the journey of an adolescent girl and young woman to sexual and reproductive health. I'm going to move through this relatively quickly, but we started this thinking it was a straight product journey. So if we raised awareness of a prevention product, let's say PrEP, we could move them on to trial, and then loyalty. So trying the product, adhering to the product, and then advocating the product. What we learned very quickly is really girls, the big overarching ecosystem that these girls live in is for sexual and reproductive health and moving to agency under sexual and reproductive health. And a lot of these findings are echoed by some of the work that A360 has done, and some of the, particularly the work at A360, and also some of the work that's done out of Gilindi. And I'm not going to go through each stage, but basically stages 1 to 3 is a stage where a girl is really trying to discover herself, find out how she navigates life, where she goes through a lot of the key points in her life. It could be first love, it could be first sex, and really how this shapes and how she sees the world and how she copes with it. And when we move to stage 4, we've got a girl who's probably a little bit more knowledgeable, is able to defend her choices a little bit better, and has a lot more agency. What we found in our research is 60% of the girls that we spoke to that were a high risk were in that stages 1 to 3, and the remaining 40 were in those later stages. But this is not linear in any shape or form. This is, some of the girls could be stuck in stage 2 forever. Some of them might be cycling back and forth between the stages. The key point here, the key takeaway here is the most important thing to an adolescent girl and young woman is that the relationship, and that's what affects her sexual and reproductive health decisions. And framing things outside of that relationship are going to cause friction and will cause her to walk away from PrEP, and are likely to cause her to make other decisions that may not be good for her. The other thing is if you're not in the right mental mode, so in that stage 1 to 3, where you're not actually able to own the behaviour of basically taking PrEP, where you're hiding that behaviour from your partner, it becomes really difficult, and that becomes a matter of agency. So again, you might find that a lot of the adolescent girls and young women that we have spoken to and put on PrEP might be on that in that stage 1 to 3, and they're not ready. They're mentally not ready to own the behaviour, and you're seeing that drop off. So that's just some framing, right? So if we move to the next slide where we speak specifically about implications of what we learned, I think the first one is clear. We've got to have providers speaking about sexual and reproductive health and not HIV in isolation. We need to make sure that providers are encouraged to speak about sexual and reproductive health and not just focus on test and treat. And we've got a question here from Deb Barron about this being in peer, whether the findings are already published or in peer-reviewed articles. Yes, they are. And there is the South Africa Health Review is going to run a story. This is one of the articles in that. So I think that's in your backyard. And there's a few other articles as well, which we can direct you to. And there's been presentations in a number of conferences as well. Okay, so moving on. The community healthcare workers feel that they don't have many options to talk about HIV prevention. You know, it's limited to PrEP, if you're lucky, condom use or abstinence. And they're finding that this is not what girls want to talk about. Sort of, it's incongruent with what is a reality in their life. So they're met with resistance a lot of the time, which leads to a lot of frustration. And also, again, if adolescent girls and young women, we found that they either avoid or lie to community healthcare workers. It's a bit like when the dentist says to you, do you floss your teeth? And we all say, yes, we floss our teeth, and really we don't, because we want to be seen as behaviours. And it's really, they're more, if they seek out the community healthcare worker, they're more likely to tell them the truth. And a lot of the times when they seek them out is when they feel at risk, when they've had some risk bump. And it's a very important stage to capitalise on this risk blip, but also to the fact that the community healthcare workers know that the adolescent girls are lying to them leads to a lot of frustration amongst the community healthcare workers and a little bit of emotional disengagement. Can we go to the next slide, please? And this first point talks to that sort of disengagement. So again, we heard both nurses and community healthcare workers being quite dismissive of adolescent girls and young women, and that frustration being that they thought that adolescent girls and young women are listening to their peers and not listening to them, that they are having problems, that adolescent girls and young women don't make good decisions, and this really tends to make them become more authoritarian and much more telling in the way that they approach them, which doesn't work. The other thing that we are learning is, while there's a lot of, or a number of support groups for PrEP support, for example, we need something broader, and something that Jalindi has done in Kenya. One of the great sort of program innovations that they've done in Kenya for adolescent girls and young women is something called a Bright Futures event, where they're talking not just about HIV and PrEP adherence, but they talk about girls in the most positive way forward, and they talk about what they can do about their futures. They really talk about positive sexual healthy decision making. And again, A360 has done this, and Japago in Lesotho has also done this. So it's about having these peer groups that are a lot broader than just discussing PrEP. The third point is that, people who empathise, so your peers or your man, or maybe sometimes the male partners, who may understand your perspective and not wanting to go to a clinic, are often not knowledgeable. And often, many times, certainly the peers know less than you, or they have a lot of misinformation. And those who are knowledgeable can't empathise. So you've got this complete mismatch in terms of what adolescent girls want to know and where the information is coming from. And then there's another point here is that influencers, the matriarchs, the community healthcare workers and the nurses all want better collaboration between them. So they don't want to speak to a girl in isolation. They really want to be having the community healthcare worker would like to speak to the mother, would also like to go into the clinic and tell the nurse what she knows about the girl, so that there is consistency in all those touch points that the girl may have with the community healthcare worker. I'm going to move this along quite quickly. Can we go to, I think maybe to the end slides? I'm conscious of time here. I'll very quickly, let's very quickly, community healthcare workers are seen as a credible source of information. They carry weight, but they're also seen as being judgmental, although less judgmental than nurses, but still judgmental. And they're also seen as confidentiality remains an issue with both nurses and community healthcare workers. And it's this whole empathy piece. There needs to be more training of empathy with community healthcare workers and nurses. The healthcare workers sort of feel that adolescent girls would be better off if they learn to love themselves and make decisions for themselves. And there's a lot of frustration around there. There is a lot of judgment around sexual activity. There is a lot of justification about adolescent girls' low efficacy and and who is affecting them. And that goes back to having some self-justification from the community healthcare workers and maybe giving up sometimes. And very importantly, they don't feel that they have enough technical knowledge to counsel adolescent girls and young women. Next slide, please. This is I'll just read the last quote because it's the quickest one. Because she is the same age as them, I think they will listen to her better than any other person they know. This is a quote from a community healthcare worker in Mpumalanga, which I think really does speak to that disconnect and that sort of almost frustration that peers have got more weight than community healthcare workers in some areas. Can we go to the next slide, please? So what can we do to be more effective? We really need to start talking about relationship management goals and speak about prevention options, and that align with the goals, the relationship goals of girls. We need to encourage girls and encourage programs to set goals that are immediately available, that are not so far down the track and unreachable that girls either lose interest or don't feel related to. We need to shift that risk framing to relationship framing. Risk is very sporadic. Our research found that sort of 60% of these girls don't consider themselves at risk at all. And similarly, the Jalindi work found that risk was not really the framework to speak to girls about. And really, if these girls do have periods of risk, is when you really capitalise to get them into prevention in some way. Post-test counselling, sometimes it's a reset button where girls think, oh yes, I'm doing the right thing. Really, we need to start talking to them about negative results being a step in the pathway to prevention. Terrific that you're negative at 17. What do we do to keep you negative at 18? And this goes back to setting rewards in a manner that is attainable and those very immediate rewards. Next slide, please. Current prevention methods. Yeah, okay, no, fine. If you want to go to the next one, that's fine. So just to remember, I am going to jump through the slides. Community healthcare workers are the first line of the first authority figures that adolescent girls go to that are not peers, partners or parents, really to get information. They're vitally important. It's vitally important that we really support them and give them the right tools. So, and that we reward their work in prevention, which is currently not the case. So really build prevention as a key focus area, give them the right tools, but also support the community healthcare workers to be able to support the adolescent girls and young women is vitally important. Next slide, please. So just a quick summary of the findings. Adolescent girls need to be given coping strategies and goals that are relevant and that we need to make sure that community healthcare workers and nurses are willing to speak to them about sort of negative things as well as positive things, but that everything is framed within that reward framework, that we really talk about sexual health in terms of her ability to manage relationships and to remember that, what a girl wants today might be different to what she wants tomorrow. She might be in a relationship or in multiple relationships today and a single relationship tomorrow. So not to assume that the girl wants the same thing all the time from the relationship. So really dig in and understand about relationships. The next point is obviously that test and treat and prevention incentives, and how do we actually make sure that we align prevention incentives with community healthcare workers. We've had lots of communication that hinges on test and treat, which is reactive rather than proactive. So again, framing prevention as being proactive but relative to them. And lastly, to really amplify the ability of community healthcare workers to be positive, to be non-judgmental, to be empathetic with the girls. That's my last slide. And as promised, I'm leaving you with a cartoon. Can we go to the last slide, please? So that is a cartoon. That's a behavioural economics cartoon. And that can be related to me. That is certainly my sister. If you ever get in the car with my sister, she thinks she's the best driver in the world and everybody is a fool. And that really talks about how you have a bias towards yourself and your ability to cope with things, and it speaks to risk. So my sister you never want to get into the car with my sister because she's an incredibly bad driver, and she takes risk because she knows what she's doing and everybody else is an idiot. And this is very much how many girls out there think about HIV. They know what they're doing. Their risk is relative. And if I went to my sister and spoke to her about better driving classes, she'd probably slap me and the way to get to her is to actually frame it about, you're in a dangerous community area. How do we make this less dangerous for you in a way that may help you get through the road? So again, not talking about risk, but talking about something that's relative to her and framing it in a very different way. Thank you very much. There's my number, and I'm sorry I went a little bit over. Sorry, guys. I'm going to throw back to
No, it's okay. Thanks so much, Annabelle. I think actually we only have one question or comment, which is actually, I think, the key question to ask, which is how are these findings being translated in practice? And I know we will hear more about that from Wanza in her presentation, but I would love for you and perhaps Manya to reflect on that.
That's terrific, and thanks, Anne, for that question. We are currently entering the pilot phase for our findings, for the work that's come out of the SA research work. So we're talking to a number of implementers. We had a massive workshop in November with implementers here. We've got our concepts that have come out of the research that were put together, as I said, with a multidisciplinary team. So currently looking to figure out which implementers we can pilot and want to pilot with us, and then really do some very stringent measurement around how much change some of the findings from this work are making in the field. And we're also working with NDOH here in South Africa to apply some of their findings to their national work as well. So we're in the process of translating these findings into practice, and Manya is also, I'll throw to Manya because Jalinda has done a lot of work and are far more advanced in translating BE and HCD findings into practice. Manya?
Thanks, Annabelle. I actually have a question for you too, so.
Okay.
I think a principle that I'm seeing that's working, and a way to think about this is how do we wrap what girls need how do we embed what girls need inside of what they crave? And if they are craving, and they are craving guidance and skills around relationships, honest conversations about relationships and challenges, and skills of how to manage and create harmony and joy in relationships of all sorts. There's a really keen desire to know about that. And when we have something like HIV prevention strategies and contraceptive strategies, et cetera, that are genuinely related to what they crave, it can be really easy to embed what they need inside of what they crave. So, you know, it's a matter of framing. If we frame things, if we invite girls into a conversation that is very relevant to their relationship concerns, then that becomes a framing that allows them to connect with these other health interventions. When we lead with the health intervention and then happen to mention relationships or you know, apply some of our gender frameworks, et cetera, inside of those conversations, they're immediately less relevant because it's not framed with the thing that they crave. So that's one way to think about it. How can you embed what they need inside of what they're craving, which is support and help managing relationships. But Annabelle, the question that I have for you is what kinds of tools and support could build the capacity of CHWs to work with adolescents? When you talk about support,
and that's a really good question. And it was interesting of what came out of some of the prototyping workshops that none of the girls in the room actually came up with any clinic interventions. They were mostly focused on either tech interventions where there is high anonymity, or community interventions where there was high support from either peer educators or community healthcare workers. And a lot of the work was really that empathy building is absolutely key. And that was one of the major barriers for girls seeking any support, even within the community. And I don't know why they didn't actually look for clinic interventions. I don't know if they just thought that there was just no point. But what we need to do over and above anything else is build that empathy, give them the tools so they actually understand about relationships and the phases of relationships. We've done some presentations to ANOVA, to the peer educators in ANOVA, and what they were the most hungry for was, how do we understand what stage a girl is in a relationship? And we've got a tool for that. Where is she in that journey, so we can understand the relationship, so we can give them the proper messaging and actually understand, for us to understand them better and what's going through their head. So we do have a tool that will tell you where in that journey the girl is, because again, the community healthcare worker, it would help the community healthcare worker with what messaging she gives, and also her mental attitude towards the girl, because she's understanding what the girl is going through internally. And the other thing is just generally that linkage piece is really important. So the community healthcare worker feels support from the nurse and the mother, as well as having that continuity for the adolescent girl and young woman. Something else that the girls were asking for, and I think would help the community healthcare workers, to actually have they were asking for a social worker, which was interesting. And that's something that I hadn't heard before. And the distinguish of why you wanted somebody who was not in a medical profession to help you. Again, I think that judgment issue is a really big one for adolescent girls and young women. So we know that they want help in the community. We know that they want help anonymously. And we know that they would prefer help from, if it's a community healthcare worker, from somebody their own age would be better. But if it's not somebody their own age, that empathy piece is huge. I hope that answers your question, Manya.
Thanks, Annabelle. I'm gonna move us forward, but I am gonna actually comment on this. I think one of the things that I've heard Manya actually describe examples of is to build that empathy among community health workers and providers. It's not enough to just share these insights that come out of the research, but one technique that has been used is this shadowing, spending a day or a half day following whether it's an adolescent girl or young woman or someone in a key population or someone else who is part of your patient base, and actually seeing what their life is like is really transformative in terms of building the empathy.
Yeah, and something that PSI in Zimbabwe did with the gender-based violence, for example, they actually had some of the prosecutors and policemen spend a night in the shelter or a couple of nights in a women's shelter for them to really understand, you know, who their client was that they were serving and what those women were going through in a different environment. So that is incredibly powerful, and that values exploration. So there is a lot of different ways of building that empathy, and you're quite right, Christine, just talking about it is not going to do it.
Thanks, Annabelle. So we're going to move on now, and I actually hear about some tools that have been developed in Zambia. Can you go to the next slide, Martha? So I want to welcome Wanza Jelasani from JSI, Discover Health, and she's going to tell us of how they've actually applied their HCD insights into tools for healthcare workers. Over to you, Wanza.
For sure. Thank you, and good afternoon or good morning, and thank you for the opportunity to share some of our experience to date. Next slide, please. So in 2018, as chair of the National PrEP Task Force Subcommittee on Advocacy and Demand Generation, USA Discover Health was tasked with leading the development of a national SBC strategy to support communication around the rollout of PrEP in Zambia. Consequently, we contracted Media 365, a Zambian creative agency, to carry out a broader HIV prevention HCD study. We decided to use the opportunity of the HCD study to broaden the focus beyond PrEP due to the vacuum in HIV prevention communication in Zambia. The study therefore sought to, on one hand, better understand the knowledge, attitude, beliefs of end users towards various HIV prevention products, including their understanding of HIV risks and factors that influence risk. Whilst on the other hand, the end user's interaction with the health system and health workers when accessing HIV prevention products and services. Next slide, please. So the study was undertaken in 3 cities in Zambia with in-depth and rapid interviews using various HCD and traditional research techniques, and populations interviewed included those on the screen, so adolescent girls and young women, males, healthcare workers, and to a lesser extent, MSM and female sex workers, all populations that are key to HIV epidemic control in Zambia. Next slide, please. I will zero in on the findings related to the respondents' perspectives of healthcare workers and PrEP in particular. So in terms of some of the key insights that we got, healthcare workers were widely seen as both a barrier or influencer in the uptake of services, much like the study that was just discussed now. A barrier in the sense that they were often viewed as judgmental towards young people and reinforcing feelings of shame and guilt about sex, especially towards young unmarried women with multiple sexual partners. They were also perceived as not being respectful of clients' confidentiality or knowledgeable about PrEP. At the time, this sentiment about the lack of knowledge about PrEP, about how to administer PrEP, was also echoed by some healthcare workers themselves. The prevailing view, however, was that healthcare workers were still a credible and trusted source of PrEP and health information. And with this in mind, it was felt that they were well positioned to play an active role in creating an enabling environment to discuss HIV prevention options, including PrEP, with the appropriate support and tools. Next slide, please. A surprising outcome from our HCD process was the development of a national HIV prevention campaign that did not solely focus on PrEP, but a range of HIV prevention options critical to HIV epidemic control in Zambia. Again, echoing some of the sentiments that were outlined in the previous presentation. As you note by the screen, the campaign aims to move away from HIV campaign fatigue and reignite interest by focusing on sexual health, well-being, and taking control. It aims to raise awareness about HIV risk and the menu of HIV prevention options, that are available to an individual. It aims to generate demand for HIV prevention products and services available, emphasizing choice to meet the user's needs and circumstances. And it aims to educate users on how to effectively access and use various HIV prevention products and services. And what you'd find traditionally, SVC campaigns tend to focus on the general public and end users, but a critical stakeholder that was identified through the HCD process was the healthcare worker. Hence the fourth bullet, which really focuses on empowering healthcare workers to be facilitators in generating demand and educating and supporting them to show empathy in service delivery. Again, the HCD process highlighted that not only did people need critical information and prevention choices, but they also had a distrust of healthcare workers, even though they felt that healthcare workers could be helpful in the uptake of products and services. We consequently developed a suite of tools to support healthcare workers and clients effectively interact with each other. Next slide, please. The tools were developed with this premise that healthcare workers have the potential to be enablers rather than barriers to the uptake of any HIV prevention products. However, healthcare workers are deficient in not only their knowledge of some biomedical options like PrEP, as well as how to be customer focused, confidential, and empathetic to their clients. Therefore, the tools developed aim to deliver on both accounts. It is essential to change the perception of healthcare workers by giving them the tools and resources to do their job and improve their reputation. So tools developed included the following: the clinic poster that you see on the top left. So these are PrEP specific tools that I'm speaking to. The clinic poster on the top left and the job aid on the bottom right that focus on increasing the knowledge of the provider to administer PrEP, while the PrEP job aid also includes counseling and communication skills and tips and guidance on how to effectively engage with the client. I'll proceed to speak about the healthcare worker app, which is on your top there, the one in the blue, the PrEP management information system, and the healthcare worker training animation in the next few slides. Okay. The animation that is about to be shown, the animation that is about to be shown aims to focus on issues related to confidentiality, empathy, and interpersonal communication. It aims to address myths that were raised by healthcare workers through the HCD process and our experience with program rollout. It speaks to the role of the healthcare worker across the service delivery cascade, with a focus on generating demand for PrEP, interpersonal communication during client-provider interactions, and supporting adherence during a client's season of risk. Using the HCD findings, it shows various vignettes of an ideal healthcare worker interacting with different types of clients, such as serodiscordant couples and young men, and also how PrEP can be brought up as an additional HIV prevention options through other service delivery platforms such as family planning. Though please note that we'll only show one vignette in the interest of time. The full video will be available through the PrEP Learning Network and the range of videos are also available on the Zambia Ending AIDS Campaign YouTube channel. So if you can play the video, please.
Hello, my name is Martha. As a healthcare worker, I'm proud of the work I do. Recently, I increased my knowledge of HIV prevention with the introduction of PrEP. First, I needed to learn everything about PrEP, including understanding the national guidelines. PrEP is a daily pill for HIV-negative people who are at a substantial risk for contracting HIV. Once I knew what PrEP was, I felt confident to counsel people on using it. A 22-year-old woman came in for her regular supply of contraceptive pills. I took the opportunity to ask her some questions about her sexual history. I couldn't show how I felt inside because I can only help my clients if I know the truth about their sexual activities. And they will only speak freely if they feel comfortable, knowing they can rely on me to be confidential. She left it to her boyfriends to decide if they used condoms or not. Because she relied on some of them financially, she didn't feel she could ask. I told her about PrEP, a pill for HIV-negative people, which gives over 90% protection against HIV. She liked the idea that she could be in control of her sexual health. She was nervous at first about having an HIV test, which she needed to ensure she was negative. I assured her that it was best to know her status and that there are many options to prevent HIV transmission. She was reassured. Now she's on PrEP and has the control of her sexual health in her hands, not her partner's. Her fear of being judged transformed into confidence and trust in me. Imagine, I changed the course of a young woman's life. I feel so proud. At first, my
Okay, so thank you. Next slide, please. So thank you. So in line with the HCD findings, the app again includes knowledge on how to administer PrEP and interpersonal communication skills and tips. It provides basic information about HIV from HIV basics. It provides information from HIV basics to actually administering PrEP, using an interactive version of the 5 steps poster that I had earlier mentioned. So the 5 steps poster is usually put in the wall of the clinicians to help them as they look at the key steps they need to take in terms of administering PrEP. So we now have an interactive version of that on the app. There's also guidance on carrying out in this case testing and HIV self-testing in line with our national guidelines. In our pre-test of the app, healthcare workers requested that we include various practical tools, such as BMI and creatine clearance calculators, and an interactive national HIV risk assessment tool that the government has just released as well. So that is included in the app itself. Finally, the app includes the healthcare worker training animation that we've just viewed, as well as other client-centered support videos. These videos are available on the Zambia Ending AIDS Campaign YouTube channel and will also be available on the Zambia Ending AIDS Campaign website and will be provided as well to the PrEP Learning Network. The app is currently undergoing another phase of pre-tests, and we hope to be released by February 2020 as an additional tool to support the administration of PrEP. Next slide, please. Another tool that I will speak about is now a Discover Health specific PrEP management information system that our organization developed to strengthen its capacity to administer PrEP. The PrEP system serves as an electronic medical record and data system. It is based on national reporting tools and custom discovered health tools designed to better capture the PrEP cascade. It has e-forms that mirror paper forms and data validation rules to reduce data entry errors. It functions offline in order to circumvent power and internet connectivity issues. In September 2019, an inbuilt appointment reminder and message schedule system was activated. The message schedule
I'm sorry, we just lost you.
Hello?
Oh,
Hello?
now I hear you.
You can hear me now?
Yes.
Okay. You can hear me now?
Yes.
Yes. Okay. So apologies about that. So so the messages, so we developed a message scheduler to support clients adhere to PrEP. The messages are tailored to speak to the commonly experienced reasons why a client may stop PrEP in the first month, such as providing tips on reducing side effects, creating that habit of taking the PrEP pill on a daily basis, etc. So and just supporting them in terms of trying to support them in the first month, especially. So what have been some outcomes experienced to date? As of November 2019, 81% of all Discover Health PrEP clients were entered into the system, which is just over 7,600 clients. Additionally, over 30,000 messages have been sent out on the PrEP management system as well. We continue to make system improvements in consultation with our providers and also continuous mentorship in its use as well. We have noted that when this in-person support is provided, data completeness improves dramatically too. Next slide, please. So what are some concluding thoughts? We anticipate that the tools developed will support our goal of increasing the knowledge of healthcare workers to confidently administer PrEP in a confidential and non-judgmental manner. We have, however, noted that there's a need for continuous mentorship and support, especially as it relates to values clarification for healthcare workers, but also in using technology as well. In doing so, we have to take a positive and empathetic approach and thus empower healthcare workers to carry out the work more effectively rather than demonizing them. However, I think it's important to end this with this final thought. Behavior change is a process and it is incremental, and therefore we should not expect overnight results, especially as it relates to values. Though the provision of the tools and continuous mentorship and support can certainly help us reach a step closer to our goals of ensuring that PrEP is administered effectively in a confidential and non-judgmental fashion. Thank you. So I see there's some questions. Should I,
yes,
Christine?
There are.
Should I? Okay.
Sure, if you want to just go, I mean, one is I think a lot of people are very interested in having access to these tools and wondering whether they could adapt them, including to other languages. And so maybe you could just kind of comment on that overall.
Absolutely. So the main tools that have been developed are Ministry of Health tools. And so we would certainly have to just engage with the Ministry of Health around their release. But fundamentally, I think it should be something that they would not have an issue with releasing. And then the app as well will be available, as I noted. So that would be available to anyone. And I think that can be adjusted and adapted accordingly. So for Zambia,
okay.
we have created some tools specific for users as well. So there've been videos, and we've used the social media page quite actively because the sub-campaign focused on young people engage young people a lot. So we developed a series of messaging around HIV prevention and discussions around HIV prevention. And thus far, we found that over 6.2 million people have engaged on the social media via social media. Also, we've had celebrity PrEP, celebrities talking about PrEP, but also just general information around what PrEP is as well that has gone out to the general public. These are available on the Zambia Ending AIDS campaign YouTube channel, but also on the Zambia Ending AIDS Facebook page, and we can certainly share as well those resources as well.
Terrific, and we can include links to all of those, the YouTube channel, et cetera, on the resource sheet that goes out and gets posted onto the Learning Network website. Let's go on to some other questions from Yolan, wondering if any of these studies were done with sex workers, how one was able to mobilize or create demand amongst key populations, especially in a context where there's no national rollout for all.
I think, sorry, I was going to say we didn't, but I know that Manya, your program did, and I think that was you, Muns, where I kicked off, so sorry.
Oh, no problem. I was just going to say that we did engage female sex workers and MSM, but it was a very small representative group. But what we found also was that I think in general, the basic information people have found informative, but we may need to just adjust the tools that to address certain subpopulations more specifically. But otherwise, I think when we did a short survey with our healthcare workers just to find out what they felt about the tools, they were saying that we needed perhaps to just make them, like for example, we have all these brochures, like making one-pagers for certain subpopulations who have maybe low literacy rates and so on. So just condensing the information, making it simpler for certain subpopulations. But otherwise, I think that the general feedback has been somewhat positive.
Just an interesting side note on that, we are looking through the options right now. We're adapting our ambassador training toolkit that was developed for adolescent girls and young women to the general population, because what we heard, the feedback we heard from the field is that some of the key for MSM sex workers, they actually didn't want to be singled out in those materials. They wanted general materials that had images that were inclusive of all populations, but were not kind of targeting them or singling them out to avoid stigma. So that was just sharing that feedback. Brian has a question on, were the HCW videos complemented by any in-person trainings or coaching? Do you have any evaluation data demonstrating how well the videos alone improved HCW attitudes and skills?
So the in-person training is a critical part of healthcare worker training, and the video is simply used as a conversation starter, because what we found was that when we started the training with the healthcare workers, there was a lot of stigma and just misgivings about providing PrEP to certain subpopulations. So the training is a key critical aspect of it, but the videos is simply there. The videos are simply there to complement that training. We're yet to do an extensive evaluation of the impact, but it's a combination. We combine the two.
Thanks. There's so many questions. I'm sort of trying to figure out where to go next. There are a lot of questions around the PrEP tracker. I'm wondering, how to learn more about the PrEP management system, and I'm wondering if maybe we should just address that in the resource sheet, or if you want to make a comment on that.
For sure. Yes, so the PrEP management system, what can I say? So the PrEP management system is something that we developed out of the need to better manage our clients. We're a part of the Discover. We have an existing electronic management system as Discover Health as well as it is. Therefore, perhaps we can share through posters and we can share through posters. It has been presented at conferences, and we share those posters on the resource site as well.
And Nikhil is asking, how is HCD used in the development of the PrEP management system or the mobile app? Were there prototypes that were iterated in partnership with end users? Is there any additional information you can share on the prototyping and iteration for those tools?
For sure. So a critical aspect of the app was developed to address the need to address the knowledge gap, as well as the counseling and other skill sets. Once we developed initial content for the actual app itself, we shared it with healthcare workers to understand whether or not it was resonating with them. They felt that it was useful. And so if you remember, that's why we added other practical tools that they could use. We have since we have actually since developed the app itself, but are taking it back now to the end users, but also the Ministry of Health. So different people that were involved in the process included healthcare workers themselves, but also people from the Ministry of Health and other stakeholders that are involved in PrEP implementation. So that's why I was also saying that we now have this second iteration of the app based on the initial feedback that was provided from the end users. And we're now going to take it back again to them to say, are they happy with how this is? And then we'll look at a release date for it, which we hope will be in February sometime. So we're certainly very much informed by the HCD process and the findings in terms of content, and then going back to end users as well to make sure that it was speaking to them.
I think we only have time for one more question. I'm going to throw this one to Manya because she has answered this question for me when I ask it. It's from Barbara Friedland. Be helpful if one of the panelists could explain how HCD differs from the tremendous body of work in the 90s and 2000s about quality of care in family planning post-Cairo. And Barbara, just to second you, I often ask this question of how is HCD different from our usual stakeholder consultations approach? Manya?
Terrified you were going to throw this question to me. And here we are. So first of all, I personally was not involved personally in all of that body of work that was done in the 90s. And I was a little bit in the 2000s. So please know that my comments here are more about how I've seen HCD be different than some of our traditional approaches to identifying barriers, addressing barriers, and developing messages. So I really think there's, or let me just talk about what I think are three key differences. One is that HCD has a different mindset. It's a mindset of wanting to delight the client or the customer and not educate the client or the customer. I mean, obviously you want to educate the client or the customer, but it's not just about building knowledge. It's about like figuring out what an interaction would look like or what a message would look like that would actually meet their need in the context of, in a more holistic context of their life, not just meet their need, not just increase their knowledge and increase their risk perception around a single intervention in isolation. A second thing is that, I think a lot of the things that we see in the HCD tool set are very similar to what we see in novel qualitative research methodologies. I would say that a difference is, I think HCD finds its theoretical grounding in grounded theory, which is a process where the answers drive the questions more than the questions driving the answers. So in a focus group or in an in-depth discussion with somebody, rather than bringing them back to the questions at hand, if the conversation wandered far away, you would ask, how does that wandering relate back to the subject at hand? And then that might warrant further exploration. So you can find out not just opinions and thoughts about the issue at hand, but opinions and thoughts about anything that group is seeing as relevant and related, and figuring out what that relationship is. And the third thing that I do think is very different is I've seen such a huge number of decisions that we make that as technicians, we have a great deal of confidence in our knowledge and our ability to shape a message in a boardroom that is going to be resonant, whether that message be through training or whether that message be through some sort of IEC materials or communications in some way. And I see that the HCD process allows there to be questions about our expertise and really seeks to engage clients, not just in terms of giving their thoughts and opinions, but also as integral to making the decisions about what is said and what is not said, and seeing them as the experts of their own experience, and very deliberately creating space for that. A final thing is this emphasis on empathy. Within JPIGO, we're calling this empathy-powered care, and looking to some of the mindset tool set and skill set within the design world to help people not just intellectually understand where a client is coming from and intellectually understand, behaviors that they should do in a checklist, but to also encourage true personalization and personal connection with what clients are going through, and finding techniques to do that, and not assuming that regular interaction with clients is fostering that personal and empathetic connection with clients, that there is something different that keeps that alive and helps that interaction be more, I don't know, it helps that interaction be more of a relationship. So that was a long response, but.
It was. My 3-point response is it's prototyping, empathy, and humility.
Yes.
But we will move on because we are over time. We're going to please ask people to do the survey. Our upcoming sessions are listed here, but let's thank our speakers, Mwanza and Annabelle. Thank you so much, and all attendees. And we look forward to talking again in the near future, and we'll share resources with a link shortly. Thank you all. Thank you, Manya, as well.
Thank you, everybody, for the opportunity.
Thank you, everybody.
Thank you. Thank you. Thank you.